Thank you, Peter, and thank you everyone for coming. And good afternoon on this beautiful afternoon. I've just come from a very rainy, flooded town, so I haven't seen the sun for quite some time. In 2004, it became medical policy in Australia to screen every pregnant woman for Down syndrome. It was called, and still is called, best medical practice, and it is now the benchmark of care. Each mother, at her first consultation for each pregnancy, is to be invited to consider the worth of her child and to submit her child for consideration of whether he or she is worth having. No benefit is stated to Australian children from this new consideration. The standard of care is actually a measure of the standard of the child. On the one hand, this new benchmark is a medical package offered to all, but on the other hand, it represents a biomedical vision which has cast a net of confusion, misinformation, despair, hazard and programmed death over Australian families. But what is it, and how did we come by it? Prenatal testing is a separate part of antenatal care. The term used generally refers to prenatal genetic testing. That's how we generally use that term. But it can also refer to ultrasound that's done in a quality control sense. Could we have the next slide, please? To understand prenatal testing, we're going to have to look a little bit back into its history and walk through the background of it. We'll be looking at its process, first and foremost, because it is universal and it's also opaque. It is very difficult to understand. We'll be looking at its enablers, its values, the verbal engineering that Monsignor Riley spoke about this morning, that preceded it, the skewed information, the confusion, poor codes of ethics, deteriorating medical oaths, and lack of disregard for concepts of proportionality, lack of disregard for hazards, and a general ignorance. We'll also look at the other processes of prenatal genetic testing that are available, and we'll look at what's new but in the distance. Now we're going to have a little walk through the background of this process, if you just bear with me for a moment. The Down syndrome net has been woven together through the last generation, and it's a complex and twisted affair laced with medical jargon. It has a screening layer like no other screening test and a diagnosis layer with no comparison in general medicine. Its design has expressed no therapeutic purpose, no intended benefit. Its implementation across Australia proposed no positive or improved outcomes for the children whom it will diagnose. The rationale for its introduction was economic, and its timing, wrapped up before 20 weeks gestation, pursues its own agenda of abortion. Its disinterest in the well-being of the child is evident from the combined peril in which it places the child and the absence of any studies demonstrating a benefit for that child. And yet, the test for Down syndrome is overwhelmingly the commonest genetic prenatal test in Australia and in the world. To be regarded as therapeutic, prenatal genetic testing must meet one simple criteria. The benefit conferred on the child would need to be more than the risk of hazard to the child. Somehow, medicine has abandoned this. Can you have the next slide, please? A major paediatric resource used in 1553 began with the promise, "My purpose is here to do them good that have most need, that is to save children, and to share the remedies that God has given for the use of man." The same promise stood its ground in the 1970s, and this very purpose appears inside the cover of Clinical Paediatric Surgery, a 1970 medical textbook. Within the 40 years since then, the promises and oaths that shaped obstetrics and paediatrics have changed. The Hippocratic Oath is of merely historical interest now. Mentored medical students invent their own, a new one each year, and small groups sometimes draw aside at graduation ceremonies to take their own oath. The current obstetric code of ethics from the Royal Australian and New Zealand College of Obstetricians and Gynecologists does not mention the baby. Barely one generation later, in 2007, we have the Medical Journal of Australia publishing a study on the rates of Down syndrome births across Queensland. This study looked at the numbers of these births, and it was checking whether prenatal screening and testing programs, which had been introduced in the year 2000, had had any effect by the year 2004. It looked at where this had or had not happened. In other words, where had the number of births of Down syndrome decreased and where hadn't they? These Queensland researchers found a significant drop in the rates of Down syndrome births in private patients, but not in public patients. They found that rural mothers had not decreased their live births of babies with Down syndrome either. Immediately after this study was published, there was a bit of an outcry. The spokesperson for the Royal Australian and New Zealand College of O&G said this data was striking and supported moves for a nationwide best practice prenatal screening policy and services. This spokesperson is also a partner in the multi-million-dollar business Sydney Ultrasound for Women, which at that time had 8 sites around metropolitan Sydney. Instead of arousing a sense of purpose to do them good, Thomas Fair's words, this result of a failure to remove Down syndrome babies aroused medical indignation. A specialist in fetal maternal medicine at Prince of Wales Hospital, when interviewed, likened it to a failure in the quality of cancer care. He recommended extra resources so that all mothers had access to screening for Down syndrome. The head of maternal fetal medicine at Adelaide's Women's and Children's Hospital said this study certainly does support the argument that availability of prenatal diagnosis is something that should be uniform. The same specialist recently gave an address on the need for genetic testing, actually 2 days ago in Melbourne. He stated figures of fetal mortality from invasive testing, which were only half to 1/3 those of consistently stated RANZCOG figures. When asked how come, he said he only counted deaths within 2 weeks of the procedure. Yet questions of death rates, of incidence and of proportionality are vital to medicine and medical decisions. A slow amniotic fluid leak after an invasive test may not kill the fetus within a certain specified time. An infection from the same leak may arise later. Cord trauma may cause deaths as the babies grow and outgrow the blood supply from a damaged cord. Within one generation of obstetric and fetal medicine, even in the upper echelons, had moved from assistance of those most in need to disapproval and criticism of their survival. Likening a failure to remove Down syndrome births to a failure in the quality of cancer care portrays these children not merely as valueless, but as negatively valued. We have indeed severed our human solidarity with them, a eugenic cut-off. It is worth noting at this point, a bit more history, it was the German Medical Association that had proposed the compulsory sterilisation law in 1932, which became the law for the prevention of hereditarily diseased offspring the following year, 1933. In 1934, the profession most represented in the Nazi Party membership was the medical profession. By 1934, 45% of doctors had joined the Nazi Party. The professional group with the next highest membership were lawyers, with only 25%. And there was no compulsion then to join. It was the allure of eugenic medicine that had attracted many into new horizons. In 1947, reflecting on Nazi medicine, and on the 50th anniversary of World War II in 1996, both the British Medical Journal and the Journal of the American Medical Association looked back on this time and said that the state had manipulated medicine. At the same time, the German Medical Association was holding its own conference, and they saw things very differently. They entitled their conference Medicine and Conscience, and they attributed Nazi medicine, meaning experimentation and eugenics, to the separation of biological power from a moral sense, to the removal of conscience from medicine. They warned their international medical peers that the tragedy of those times was not mere happenstance, and that the doctors involved had abandoned conscience and dismissed morality. 7 years after this warning, an article in Australian Doctor proudly announced that Australia led the world in Down syndrome screening. Professor Sheffield, a clinical geneticist at the Murdoch Children's Research Institute, regretted, though, that there was still room for improvement. Some states had not yet maximised their detection methods. He was quoted seeking a national consensus on Down syndrome screening. "We've been trying for years," he said, "but there is resistance from politicians. So each state has to cope with their own allocations for screening." The following year, the Royal Australian New Zealand College of Obstetricians and Gynecologists endorsed national Down syndrome screening as best medical practice. This designation usually implies things like an evidenced reduction in mortality rates, or a demonstration of enhanced 5-year survival, or at best a presentation of scientific data quantifying the benefit of testing for the individual tested. This is evidence-based medicine. Normally, evidence-based medicine is known and respected around the world as a standard of care. In the case of Down syndrome, though, we have other figures. Denmark proudly announced in the British Medical Journal of 2008 that it had only delivered to life 31 Down syndrome children the previous year. Can we have slide 4, please? The earliest amniocentesis for fetal chromosomes for Down syndrome was in 1968, and ever since then we've been doubling our efforts. It was initially offered to older women because as we get older we have more chance that our eggs might have a problem with their chromosomal division, and we have a higher chance of Down syndrome children. But offering it to older women didn't catch enough Down syndrome children. It caught about 30%. However, it came in as a program starting off with these women, and the Sentinel article of Medical Research, which launched it, concluded, "Where abortion laws permit, there is no need and no justification for delay in trying to institute a prenatal diagnostic screening program for Down syndrome. To effect the policy advocated here will bring relief to the community and new assurance to prospective parents. But medicine's dissatisfaction with a 30% Down syndrome pickup was growing and was preparing in the background. 70% of Down syndrome children were being missed, but also raising concern, as was later referred to in the International Journal of Medical Sciences in 2005, this advanced maternal age group had included a disproportional number who would not accept termination for religious reasons, and it included many who would not accept the hazards of invasive diagnosis. So as the decades passed, techniques of detection escalated to maximise live birth prevention of Down syndrome, to produce what we have now, which is a curly and convoluted program of screening. Within this maze, we now are at 90% detection of Down syndrome, with, in Australia, 94.7% aborted. And we're still not satisfied. Slide 5, please. Now we need to look at the process, and I'm sorry, but there's a lot in the process which is, it depends on people not understanding it, so we're going to unravel it. We know all pregnant women are now offered to have prenatal screening. Some may say, and do say, that it's only offered, but medical magazines, peer-reviewed medical journals, and allied health articles on prenatal testing studies now refer to it as recommended, essential, advised, important, and routine. There's a New South Wales Health Department pamphlet, The Importance of Checking Your Baby's Health Before Birth, is the pamphlet heading on the prenatal diagnosis brochure that relates to this. The importance of checking. So it may be an offer, but it's heavily worded. This combined first trimester screening that we're about to talk about gives every single pregnancy a number. So it gives every pregnancy, every baby, a risk number. And it's generated from a fetal medicine software package, which is patented. And so it takes a bit of unravelling in there too. It involves a combination of multiple pieces of information. From the mother's blood, it measures 2 pregnancy hormones. And it also measures the ultrasound width that's detectable of the fetal neck at 12 to 13 weeks. Have you on the slide, please? There's about a 2-week window in the pregnancy where all this information can actually give you a likelihood ratio that a pregnant mother's growing son or daughter has Down syndrome. Now, I'm walking way too far from the microphone. I know it's a grainy image, but the nuchal translucency is not normally quite that hard to see, but it's about 2 millimetres on the actual ultrasound screen. So you can imagine that that's got quite a bit of room for observer error, and there's a lot of training that goes into getting ultrasound technicians to be able to measure 2 millimetres. What confuses many people, and many doctors too, is that this is not a screening test for a problem, but a massive population net to see who is in the top 5% bracket of risk for having a problem. Its aim is to separate out all those who are in the top 5% with a higher chance of having Down syndrome from the other 95% of babies in the population with a lower chance of having Down syndrome. Screening tests locate who is in this higher risk end of the population for possibly harbouring Down syndrome babies. They become the target group. Now I'm just going to, because there's different ways of expressing that, I'm just going to draw it. So if this is sort of like a column graph, and if it represents, say, the population of pregnant, oh dear, not very straight, population of pregnant women, so the whole thing, you know, is 100% all pregnant women. These tests that I'm about to explain are designed to work out who's in here and who's in here. And this then becomes a new target group, whereas before you had women over 37, now you've got the whole population worked out to see who fits in here.
Just hold it here if you want.
Not working, hey. Sorry.
You're right.
Yep. I'll take that next time.
Yep.
Thanks. Those above this line who land in the target group, and 5% always do by definition, are 1 in 20 mothers who are offered a very different second test. The next test is the one that actually gives the diagnosis. It's more than a measure of chance. It's the chromosome karyotyping, but it's not 100% either. It's achieved by either a sampling of the actual placenta, consider it like a biopsy of the placenta, or it may be from the withdrawal of amniotic fluid, in which there will be fetal skin cells, which obviously carry the chromosomes of the baby. This sampling is known as invasive testing because it enters the uterus, or it can be called diagnostic testing. This next test, though, is also the one that has unacceptably high mortality rates, as we'll explore later. These measurements, though, which together form the combined screening test, the 2 blood tests, the ultrasound, put together, put into a fetal software program that give you the risk, they're not necessarily looking for abnormalities individually. Rather, they're measuring the smallest differences of blood levels or neck space width from the median or the middle values calculated for the population. So in other words, how far are the babies or the pregnancies measurements from the dead middle of the population range? These scores are known as multiples of the median. They are small, proportionate digressions, and everyone has them to some extent. No one's the same. Each measurement or score is then adjusted for the fetal age because it's in a 2-week window, so the baby could be 12 weeks or almost 14 weeks. And a software program, as I've said, then calculates a likelihood ratio. But on top of these measurements, you've got the maternal age. The likelihood ratio from measurements is then multiplied by the mother's own expected age risk. Now, as we get older, I had my last baby at 40, so my age risk just from my age, which all mothers know kind of what the age risk is when you get past about 35, was 1 in 90. So what that means for these mothers is that they're having the test done, they already know their age risk for Down syndrome, and then they might get a phone call saying, oh, I'm sorry, you've screened positive for Down syndrome. But in fact, their blood markers, their nuchal translucency, might be exactly the same as those of a 22-year-old. But multiplied by the age risk she already knew will tell her that she has screened positive. And in fact, at age 35, the test is designed that 10% of women will screen positive. I'll go into the false positive rates a bit later on. So we multiply the biochemical markers, the ultrasound, through the fetal software package by the mother's maternal age likelihood ratio, and then is printed out her figure for that pregnancy. It might be that she has a 1 in 50 chance of Down syndrome, it might be 1 in 2,000, it might be 1 in 2. That line, which is drawn across the 95th centile that I clumsily tried to draw there, of the population of Australia, is drawn at a risk level of 1 in 300. So those under it will have a result which says the risk of Down syndrome, trisomy 21, is less than 1 in 300. Those over it, those who've landed in this target group, have a risk of more than 1 in 300. And of course, as I said, at that cut-off, 5% of the population will have a risk of Down syndrome. That's more than 1 in 300. This is a statistical arbitrary line. The Royal Australian College of Obstetricians protocol is to consider any chance of Down syndrome that is more than 1 in 300 chance as a positive or high risk result. And that is where the cut-off is set to advise invasive testing, amniocentesis or chorionic villus sampling. To put this in perspective, I often say, imagine if you had a test for diabetes. We're going to screen you for diabetes. This is your diabetes test. Now, you have the test done and you're waiting for the results, and you get a call from the doctor. Oh, you better come in, you've screened positive for diabetes. So you go into the surgery and you put work off and you arrange your kids or whatever, and you turn up and you're told, oh, I'm very sorry, but you have a 1 in 300 chance of having diabetes. You can imagine the proportionality of this thing is not enough that should be of anxiety or concern to parents. There's no test that can tell you that child is perfectly normal. Until that child is placed in your arms, it's what every mother goes through. Slide 7. With figures like this, the test is obviously going to have a very high false positive rate, and it does. The screening test, as I said, is only screening for the risk of Down syndrome, merely trying to determine a manageable target group. The RANZCOG, Royal Australian New Zealand College of ONG, and the Murdoch Children's Research Institute patient handout in 2008 stated that only 2% of this screen positive group will actually have Down syndrome. So that means the incidence of Down syndrome is 2% of that group, 2 in 100, but 2%. So if I draw a red line across the top, that's about how many Down syndrome children are actually in this target group that's being invasively tested. So that means 98% of those who are invited to have this test and put their baby through the risks, which we're about to talk about, and the miscarriage rate, do not have Down syndrome, and that is known beforehand. The screen positive rate is almost equal to the false positive rate. There's no other screening test in medicine that can claim that. Now, why this 5% cutoff was selective is interesting. The false positive rate, this enormous false positive rate, was considered to be about all the community could accept. In addition, the false positive rate, that much is needed to pick up around 90% of the Down syndrome pregnancies, which was their target. That pickup versus the false positive rate will deliver a pretty good benefit to cost ratio for the economists. It doesn't want, and the fourth reason they chose that line is it doesn't want the percentage of pregnancies with Down syndrome to get too far ahead of the invasive test's own mortality rate spent looking for them. The next step is invasive testing by chorionic villus sampling or amniocentesis. Mortality rates of this are not nationally audited. So we go on figures assessed and compiled by the Royal Australian College of ONG and the Murdoch Children's Research Institute. And the fetal death rate of chorionic villus sampling, biopsying the placenta, additional to the ordinary miscarriage rate, that's the additional fetal demise from this test, from chorionic villus sampling is 1 in 33, up to 1 in 33. So up to 1 in 33 babies tested by chorionic villus sampling will miscarry. The fetal death rate additional to the miscarriage rate for amniocentesis, that's taking out fluid at about 16 weeks, is consistently given as up to 1 in 100. A UK study, United Kingdom study in 2005, has shown that fetal mortality rates from invasive testing are 6 to 8 times higher than the stated average for specialists in training. All specialists in training, all specialists have a training phase, and that's what our public hospitals do. Invasive testing has mortality rates that would be wholly unacceptable for a test in any other field of medicine. For a non-therapeutic test, this would be abhorrent. No treatment is planned or possible for having 47 chromosomes instead of 46. That's slide 8, thanks. This is Down syndrome, trisomy 21, where the arrow is pointing to those 3 smaller chromosomes. So instead of the 23 pairs and 46 total, there's an extra 1 tacked on to the 21st pair. Can we have the next slide? The screening test that issues the risk for Down syndrome will also be telling parents of the risk for these much rarer chromosome problems. There are some incredibly rare chromosome problems that are fairly lethal to the baby in themselves. They cause some very serious brain and heart and kidney problems. The babies may well be born alive, which is beautiful because it means they get to meet their mum and their dad and their brothers and sisters. They may die shortly after, Some will live a little bit longer than others, and there is a range. But that meeting, that first meeting, is so important. Unfortunately, they are also the ones that medicine is aiming to delete from the system, so that they don't get to meet their parents. They don't get to have that very short time they might otherwise have had. So why do we look for these chromosome problems so assiduously? Have the next slide, please. Yes, Down syndrome can have a range of problems. However, just knowing the chromosome count will not tell you which particular problems they have or how severe they are going to be. Yes, there are, I know it's a complicated slide, there are heart and gastrointestinal malformations that may be present. Celiac disease, hypothyroidism may develop. Neck instability might come to surgery later. Dementia, Alzheimer's may develop. Intellectual disability is a feature of the condition, but children with Down syndrome learn and develop throughout life, albeit at a slower pace than usual. Literacy rates for Down syndrome are just over 40% and have been improving. Symptoms can be treated, and early intervention programs help to develop their potential. These problems, though, are judged to be an intolerable burden on the individual as well as on society. The screening is to find where in the community to focus the diagnostic effort, and the diagnostic effort is to talk about choices. As I said, when eventually tracked down, 94.7% are terminated. For every 100 babies invasively tested because they've screened positive, all 100 are placed at hazard. No matter how much the doctors say we try, we do this, we have ultrasound, we do everything, and they do all those things, and they do try not to cause harm, of course they do. But you can't keep a child still. But it isn't so much that the needle hits the child. The cord can flick on. You've broken the sterile place of the amniotic fluid. There can be infections. There can be a leak that just persists and persists from the time when the fluid, when the membrane's been perforated. So no matter, in the very best of hands, in the very best efforts, it's difficult to say, well, in my hands, you can't, which specialists do, in my hands the rate is, 1 in 500. Well, I would challenge that, in fact, and I do. The mortality rate from testing is shielded from scrutiny by the lack of a national audit, by the not recording of miscarriage beyond a certain time, and by a certain professional lack of rigour in this department. I should add that if parents miss the window of screening for that 12-week screening test for Down syndrome, there's another one they're put through at 16 weeks, so they're not off the hook. There's another test not as effective, just a blood test at 16 weeks. Now, the overall false positive rate I mentioned, I just will briefly say it was 5%. At age 35, 36, it's 10%. At age 44, it's 47%. So it's aiming to pick up that 90% of Down syndrome in the population. But there are other issues. The pregnancy hormones change over the interval of time for collection within that 2 weeks. In a Sheffield laboratory a few years ago, there was a laboratory computer problem, and lots of mothers were given the wrong Down syndrome assessment. How often, I wonder, does this happen? In 1996, the National External Quality Assessment Scheme in the United Kingdom sent dummy patient results around to different laboratories, and they found a huge variation in results. The coefficients of variation were 36.5%, 31.5%, and 55.6% for the different methods used. Although trained and specifically accredited by the Fetal Medicine Foundation, ultrasonographers measuring tiny fetal necks and tiny fetal neck spaces are not immune from human error. The software calculation is a black box poorly understood by its users. Can I have slide 16? In addition, it has been found that less than 10% of healthcare professionals allied to a tertiary level maternity hospital are able to provide accurate information on the characteristics of screening tests for Down syndrome. And these are the creme de la creme. In an Australian study of obstetricians and of GPs who regularly look after obstetric patients, 47% did not know that 5% of screened mothers receive a high-risk result. And there were only small correlations between perceived knowledge and actual knowledge. So after they answered the questions, they were asked to say how confident they were of this answer. And a lot of them gave 4s or 5s that they were very confident or they were absolutely confident. 1/3 did not know what the false positive rate was. So about half knew that 5% screened positive. 1/3 didn't know what the false positive rate was. A BMJ study in 2006 evaluated the knowledge of obstetricians and midwives over in the United Kingdom and also patients. Of the obstetricians' responses, 43% were correct. There were no correct answers from midwives and 9% correct answers from patients. And this was after they'd had the screening test done. Despite the rate of errors, obstetricians again ticked confident in their incorrect responses. The Professor of Biostatistics at the Australian National University Centre for Epidemiology and Population Health commented on this study. He said not knowing what a positive result meant could create more alarm than necessary. Providing patients with a leaflet containing relevant information and explaining about the probability of a patient having the condition after a positive result could be helpful, he said. The research article itself expressed concern that the impact of inaccurate estimates would be magnified if those making them were confident in them. How do they counsel mothers? And how do these mothers ever give informed consent? But there are also commercial interests here. It's big business. Ties exist between national policy making and business. A major National Health Service report in the United Kingdom promoting universal Down syndrome screening had a lead author who also directed the company which marketed the required software. The frequency of pregnancy means large numbers of people tested and large incomes, even with small profit margins. It's interesting to note that when Röntgen invented X-rays, he waived the patent for the good of mankind. His letter where he did that's actually on display right now as we speak in Canberra. If you get a chance to go there, it's beautiful to read. The same happened with the polio vaccine. The patent was waived. I think probably fortunately altruism is not a feature of prenatal testing. After the screen positive result, with all its conundrums and the offer of an invasive test, its hazards are to be considered, its purpose is to be considered, and for all this there is genetic counselling. I might jump to slide 17, thanks. Following an increased screening test, many mothers are referred to professional genetic counsellors. And the aim of this is, quote, to receive information and support in decision making about subsequent diagnostic testing. From an ethical perspective, informed decision making is a central goal of prenatal genetic counselling. In 2009, an Australian study explored current practice in prenatal genetic counselling in 2 tertiary referral maternity hospitals in Victoria. This study was published in the Journal of Genetic Counselling in 2010. With consents, 5 accredited genetic counsellors at 2 of these hospitals in Victoria had their de-identified client interviews audio taped over an 18-month period from 2003 to 2005. 52 mothers were approached to participate. They had risks ranging from a 1 in 4 chance of Down syndrome to a 1 in 296 chance of Down syndrome. 31 women agreed to participate and have their interviews taped. 20, where's the remainder? I'm trying to do the sums in my head. The remainder, anyway, declined to participate because they were too distressed. They were too distressed. The study found, I'll just go through the points, the conclusions of the study first, that the majority of clients demonstrated a poor understanding of the screening test they had been given. Or we could have told them that, I suppose. 2, the genetics counsellors only offered explanation of procedure-related miscarriage in response to specific questioning. And then the figures for risk were given, but they weren't Ranscog figures, they were some other figures, much lower than Ranscog figures. So only if they were asked did they say, by the way, this test will kill your child this many times. Couples were sometimes advised to consider whether they could cope with the uncertainty of not knowing for sure without a diagnostic test. Well, most counselling helps clients manage uncertainty, doesn't set out to provoke it. And then there was misinformation given. One genetic counsellor advised a client with a 1 in 82 risk of Down syndrome that Down syndrome babies can have serious heart problems, she said, but nothing we can do in pregnancy can test you for that. Well, that's not true. There are fetal echocardiographs, there's fetal ultrasound. And that's available even without chromosome diagnosis. Another counsellor said, we do know that kids and adults with Down syndrome are always dependent on their parents. Well, that's not true either because many of them leave home. One counsellor was asked what Down syndrome could mean for a baby. She replied, after mentioning the intellectual disability, quote, perhaps doesn't offend anybody, and these children with Down syndrome have a particular facial appearance about them. So their eyes are sort of more slanted and they've got sort of loose facial skin appearance. Sometimes the tongue is bigger and sort of hanging out, and so there's sort of a particular sort of appearance. No proper discussion of the variables and the variable incidence and the variable severity of these problems. No mention of literacy rates, of actors with a diagnosis, of people with Down syndrome having their own websites, of being active and contributing members in the family and in the community. Only 2 of the 21 sessions offer clients a brochure from the Down Syndrome Association. The study itself observes, at the end, at no time did any of the counsellors talk about any potential for children with Down syndrome to contribute to family life. There was no overt encouragement of clients to deliberate about the possibility of having a child with a disability. And there was commonly a notable reluctance on the part of counsellors to talk about how an abortion may be performed. Counsellor 3 said, when she met the client, your risk of Down syndrome has come back at 1 in 51, which probably comes as a huge shock to you. Well, if the mother wasn't particularly anxious, I think she will be now. Only one counsellor mentioned to the mother that if she would not consider an abortion, there was no point in risking the baby's life with amniocentesis. Concerning the possibility of Down syndrome induction with a mini labour, this was mentioned, but never that it would result in a stillborn baby. Adoption itself was never mentioned. One of the conclusions of this study was, this information given about Down syndrome in prenatal settings is generally inadequate for informed consent and also emphasises the negative aspects of the condition. Informed consent and choice are often misdirected by misinformation, pressure from pamphlets, negative values assigned to Down syndrome, covert values about disability, concealment of economic rationales, and fear that the non-participation will jeopardise the cost-benefit ratio. Apart from genetic counselling, there are other sources of poor or misinformation out there. The West Australian Department of Health has a printed patient information booklet dated 2008. It was largely put together by the Centre for Genomics and the West Australian Fetal Medicine Unit at King Edward Memorial Hospital. The first page contains a glaring error. It says a screening test can tell you if Down syndrome is likely or unlikely. It doesn't, it can't. It only gives a risk assessment up to 1 in 2. This misinformation steers people towards testing. I usually inform about mistakes where I find them, and the fetal medicine maternal specialist who advised and signed off on this document said I was being picky. They did not correct it until 2011, but it was on the website and distributed for 3 years. If these mothers had then turned to a bioethics centre in Western Australia, they would have received their advice that mothers who screen positive for Down syndrome, 5%, if they don't have Down syndrome, probably have another abnormality. They notified twice of their mistake, once through their governing body and once through their chief signatory specialist. They did not amend their information until it was made public in the secular press. They also gave mortality rates that were half to one-third those of Ranscog. If mothers in Victoria turn to a well-known Melbourne Bioethics Centre for truthful information, they may be given the information their director gave to a colloquium of bioethicists in 2011. Published last year in an autumn edition of a Christian health magazine as debate and distributed to healthcare agencies everywhere, it stated that because prenatal screening and testing is best medical practice, it benefits the health of the mother and it benefits the health of the child. Prenatal testing, it published, safeguards the pregnancy and safeguards the health of mother and child, but wasn't able to say from what. And Pregnancy Help also, I have to say, we're using an information booklet from Sydney Ultrasound for Women. Like most other resources, it overstated the Down syndrome incidence by saying screening positive didn't necessarily mean that you were having a Down syndrome baby. It didn't say only a tiny percentage do. The federal government, were the best actually, the federal government had also given incorrect advice on their Biotechnology Australia fact sheet number 21. They spoke of of screen-positive mothers as having abnormal results. When they were notified, explained the test and explained it wasn't really abnormal, just digressions from the dead centre of the median, they were actually very courteous. They wrote a lovely letter and they took it down from the website. And the federal government gave the best response of all the other people whom I've notified over time that they're giving misinformation. But why is this prenatal testing process best medical practice? I have to watch my time, but we might go quickly to slide 19. And I might just have to summarise here. It's best medical practice because it meets the economic rationale of a cost-benefit ratio. And they have taken into account the cost of abortion, the cost of grief counselling after the abortion, the cost of transport to and from abortion services, because they recognise that these things exist, the grief, and the counselling afterwards. So it's very much a cost-benefit analysis. One of the conclusions, recent economic analyses have shown that population-based screening probably represents value for money. This is the Medical Journal of Australia talking here. Recent economic analyses have shown that population-based screening probably represents value for money. When the costs of screening are offset against the lifetime costs of caring for a person with Down syndrome, screening is less costly than no screening at all, regardless of which strategy is used. And then the Australian New Zealand Journal of O&G said, for consideration of national policy, cost-effective screening programs will be significantly compromised if the participation rate is low. The cost of the screening program to detect a certain number of cases has to be balanced against the cost of managing missed or undetected cases in the population. The benefit to cost ratio greater than 1 indicates it's worth doing. Let's go to page 32. In testing, the other forms of prenatal testing are for a single gene abnormality, that's like muscular dystrophy or thalassemia, haemophilia. And there's no screening test for those. So the mother has to go straight, if she wishes, if she's, for whatever reason, thinks that she needs to, go straight to an invasive test. But you have to ask the question, is this going to confer any benefit on the child that's proportional to the risk in which you are placing the child? That's a common Hippocratic principle. It's also the Evangelium Vitae principle, and it's also basic logic. When do we need to diagnose something like that? Diagnosis can often be delayed. If amniocentesis must be done, it can often be delayed towards the end of the pregnancy, when the risk of prematurity is much less final than the risk of death. Of 3,978 invasive prenatal diagnostic tests done in Victoria in 2007, only 113 were for single gene abnormalities. The rest is all for Down syndrome. Many of these mothers, though, are pushed into prenatal genetic or pre-implantation genetic diagnosis Now, I don't know whether we have time. Where's my person to talk about it? If we don't. Okay, just briefly summarise. People are encouraged to go into pre-implantation genetic diagnosis to have, as Monsignor Riley referred to, have their baby's quality checked before the baby is implanted. Now, the big promo on this is that it avoids a termination. How do they get to that point? They say the baby isn't really a baby until after day 6. So they do all this before day 6. And that's from the definition of the International Federation of Obstetricians. There's a testimonial written in their newsletter, Conceptions, from Sydney IVF. And in this testimonial, it thanked Sydney IVF for this couple who wanted to avoid the heartbreaking decision of terminating. When we read on, we find they had 8 tiny embryos. They implanted 1, they froze 2, and they discarded 5. It's no wonder that parents feel they can't outrun this. They've been pretty much left to outrun it on their own. Without fully understanding what's happening, without the language, without facility with the factual details, without the support of the onlooking community, without graduating medical oaths that might have protected them from the medical culture and from us from ourselves, and without the medical colleges who have fallen one by one to this policy. The College of Obstetricians, the College of GPs, the College of Pathologists, the College of Human Geneticists all advocate universal prenatal screening. And now, even without the support of bioethicists. Misled, in fact, by bioethics centres, which seem to be focusing more on being cooperative and reasonable than on producing factual information. An article in the recent Messenger magazine pointed out, our generosity may be rather limited, but we have tremendous capacity to grow in love. It is this that we underestimate. And it is this that our medical colleges have lost touch with. It's the source of our creativity with God. We need to give these parents the confidence and the courage to rise above all this, the information in a form they can digest, so they can breathe, as Tolkien would say, to breathe the free air again. But not just free air. They need air lit with understanding and enriched with the guidance of the Holy Spirit. Thank you.
Thank you, Deirdre, for that. You have become quite an expert, and thank you. I want to know, when are you going to find the time to write that pamphlet and get Paul Hanrahan to publish it?
We'll just have one more question.
Thanks very much for your talk. It's wonderful. In recent years, there have been some efforts to reduce the incidence of other disabilities such as spina bifida. I wonder whether you could close in with how that impacts on the type of things that you have been talking about.
Yep, no, thank you for that. The availability of the ultrasound service is often much misunderstood. I'm actually a great supporter of ultrasound. It's a wonderful test, gives a lot of information, it's got to be used the right way. It's non-invasive, doesn't hurt the child per se. However, I've just outlined a medical culture which is developing and which I think is quite fierce. And that medical culture is what is misusing a lot of the ultrasound technology. And in fact, unfortunately, babies with spina bifida are not helped by that medical culture. What should be happening is babies with spina bifida, now that we have so many more facilities with surgery and fetal surgery and all of those techniques, we could be beginning to assist these kids and working out ways of helping spina bifida, even in utero. But instead of that, the money, the efforts, and even, if you like, the academic focus is going into detection, measurements, special courses to learn to measure 2 millimetre, all this sort of thing. So that's draining our academic interest and enthusiasm into a eugenic area, away from productive, creative, therapeutic medicine. So I don't blame the ultrasound, but definitely the medical culture spina bifida kids have got an uphill battle, and they need someone to speak up for them, because there's not many people in the medical world, once it's diagnosed, who will actually sort of come in and ride with the parents, you know, on that pregnancy. So thanks, Daniel.